Yeah, I don't know. Great. Right, thank you. We'll get started. So thank you for everyone here in Atlanta in person. Thank you for all those who are joining online. And welcome to one of our glue lectures here in Atlanta. So real quick, my name's Wilbur Lamb. I'm a physician scientist at Emory University, Children's Healthcare of Atlanta, and Georgia Tech. I'm one of the principal investigators, along with Dr. Greg Martin, Dr. Oliver Brand, of the NIH-funded Atlanta Center for Microsystems Engineered Point of Care Technologies. And our GLUE lectures, which stands for General Lectures Uniting Everyone, is really about biomedical technologies in the point of care diagnostic space and uniting technology developers with clinicians and also incorporating learners as well. And what we do is have these periodic lectures of which we bring in speakers, including Dr. Mina. So it is my distinct pleasure to welcome Dr. Michael Mina for numerous reasons. One is that he is an alumnus of Emory University here in his MD PhD program. You know, Mike, I was trying to think of some pithy statement about that, and the only things I could think of was like Return of the Prodigal Son, or like Carry On, My Wayward Son. But that's like, first of all, the first one's bad, right? And the second one is like a classic rock song. So the only thing I can think of is Welcome Home, Dr. Mina, right? So Michael, after he got his MD PhD, did his training up in Boston, and he's a pathologist, he's an immunologist, public health guru, and he's had appointments at Harvard Medical School, at the Broad Institute, and most recently he's become Chief Science Officer at UMed. And during the last several years, Michael has really established himself in being a key opinion leader when it comes to diagnostics, especially in the COVID-19 space. And yeah, and for those of you that might know on social media, he's got a bajillion followers on Twitter, and he's in the news all the time. So if this is the first time you're seeing him, I can guarantee you it's not the first time you're hearing him, because he's on the radio all the time. In fact, Michael, I don't know if I told you this, you and I had a few calls over the last few months, and I think I hung up with you. I was in my car. I hung up with you, and then NPR was on, and you were on. It was as if I was continuing a conversation with you and Terry Gross, I guess, right? So, but anyway, welcome to Dr. Mina. He'll be talking about testing in the pandemic, where medicine and public health conflict, and dogma rules the day. So thank you. Let's welcome Michael.
Well, is there a microphone that I'm supposed
to? You just project. I think the microphone's on the ceiling. So to everyone else, please turn off your phones. Please talk. Pretend you're in a movie theater.
Well, thank you. And it is exceedingly nice to be back here. And so I wanted to talk today. I had a few things, and I hope that I will come back to talk about a different topic that I'll just introduce right now, which is an idea of how we can use immunological tools to create kind of a weather system for viruses in a program that I call Global Immunological Observatory. I'm not going to talk about that today, but I want to come back at some point and talk about it, and we've discussed this. But today I'm going to talk about testing in a pandemic, and the focus is really to think about how does medicine differ from public health. Most of the approaches we've taken to evaluate diagnostics, most of the public discourse around the tools we use to identify if we're infected with a virus have been driven by a long history of diagnostics really being first and foremost medical devices, medical tools, which that makes perfect sense. But the pandemic showed us, along with some other public health issues in the past, just the importance of testing in a pandemic when the purpose of testing might not necessarily be for medicine. And so I want to go through this. And for those of you who might have heard some of these concepts, I'm hoping there are some people here who very little I say today is surprising. But I'm also hoping to drive home some major points that are often missed. These are some of my disclosures. I am Chief Medical and Chief Science Officer of a company called EMED. I'm a medical advisory board member for a catalyzer company that one of those companies makes a molecular diagnostic test. I have no shares in those companies. And then I'm a board of director of a protein sequencing company. So testing in a pandemic is not just about medicine. It is a crucial public health tool. We saw this at the beginning of this pandemic. Most people were lining up to find out if they were safe, to use a test to find out if they were safe to go and see family members, to understand if they could go to work, to go to dinner, to just go into their bubble with their friends and kind of start being in a bubble. So a lot of the reasons that people have been testing are not just medicine. And so we can test for personal health, but we can also test for population health. Personal health is what we usually think about. It's also really around how the devices that we have access to are authorized by the FDA. It's how doctors think. And it's really, you use a test to figure out, are you sick? Do I have a problem? Do I need to get treatment? And there's different metrics that we might want for a test that a doctor might be performing or that we're performing on ourselves for medical use, compared to a test that's for public health, for population health, and that might be surveillance or screening. Screening doesn't have to be a medical purpose. 1,000 people coming into a campus to start their first day of school who are getting tested for every day for the first 5 days, that's not medical testing. That's purely a public health good, for the most part, especially in a time before oral antivirals were existing. And so the purpose of this slide is to show that there are different attributes that you want to see in a test depending on what the use case is. So things like sensitivity, things like specificity, things like the frequency that a test can be used. A doctor doesn't need a test that you can use every single day on the same patient because you're only going to see that patient once every few months, maximum usually. But a patient who maybe is going into an individual who has an elderly family member or vulnerable family member who works on a factory floor and just wants to make sure they can come home and not expose their family member, they might need a test that's highly, highly accessible and very, very cheap. And the benefit of having that access and that frequency might massively outweigh any small losses in sensitivity it might have relative to a test that they can't access and therefore have zero sensitivity. So the metrics that we evaluate tests against which have to be based in the question we're asking and the purpose we're asking. And this is really what a lot of the conversation is going to be about. So this is kind of the simplest strategy that I can come up with to say, why am I doing this test? Am I doing this test for medicine or am I doing this test for public health? When the primary beneficiary of the test, the person who's getting the swab stuck in their nose, when the primary beneficiary is that person, then it's probably a medical test. I want to know for me, I'm benefiting from getting a test. That's medicine. That's, or at least it's in the realm of medicine. But if the primary beneficiary of me using a test is not me, but all of you, because I'm standing up here without a mask on speaking to you, then that's probably a test for public health, where I want to test to make sure that you're all being safe by being around me. Or when the consequence of using the test is not one of medicine, but the consequence of getting a positive on that test is something like isolation, that might give you a hint that you're actually using the test primarily for public health. Because I don't know, how many people here are physicians? Of the physicians, how many of you have prescribed isolation to a patient for the patient's own good? Nobody, no doctor in the world would prescribe isolation to a patient. It does the patient zero good. It's a net negative from an individual perspective. It harms your psychiatric sort of ability to get through your infection. There's all kinds of problems with isolation, but it is the consequence of using a tool for public health because we know that it's in the benefit of your family members or your friends or people you're around. So we don't normally think of testing in these two domains, but it's extremely important because it totally changes the qualities and metrics we look for when we're thinking about testing. So this might be the usual priority order. If we look at what does the FDA look for, or if we look at what do most physicians think about when they're saying, do I want to get this test for my patient? Is this the right test or laboratory directors? In the case of a viral infection like this, we look for really high sensitivity. We definitely want really high specificity. Cost is usually, FDA doesn't even think about the cost. Speed to get the results. We had a lot of tests coming back after 7 or 10 or 14 days in this pandemic that were authorized. They were the only tests authorized at the time. And so speed and cost, they generally haven't played much of a role in our decision making. We're so focused on sensitivity and specificity at the expense of all other metrics that are just as valuable, and as I'll show, are actually much, much more valuable than the actual sensitivity. And so for pandemic testing and for public health testing, you want tests that are fast because you actually want it to be actionable. Somebody's infectious and spewing out 10,000 viral particles in every breath. You probably want to ask them to get isolated as soon as possible, not 7 days after they've been infectious. You want it to maybe be able to use a test frequently. You want it to be convenient. If a test isn't convenient, it's not going to be a good public health tool. These represent test characteristics that are really important for public health, but maybe a doctor would rarely think about. Speed is one that a doctor might think about, but generally they kind of, allow the labs to figure that out. A doctor prescribes tests, and if needed, they say, go home, I'll give you a call back when your results are ready. And that's usually fine. So rapid tests in this pandemic have a really unique ability to detect virus when it's most likely to be transmitted. So what I'm showing here is what a general viral load curve looks like when you get an infection with a virus like this. It's actually pretty similar to flu as well. And what you're seeing here is that when somebody gets exposed, no test finds you as positive. PCR will be negative, rapid antigen test will be negative. After a few days, this incubation period, the virus starts growing, and it starts to pass a limit of detection where PCR might turn positive. And then usually within around somewhere between 12 and 48 hours later, it will pass the limit of detection for a rapid antigen test turn positive. And then the virus grows very quickly. At this point, it's racing north, it's exponentially replicating, it's depleting all the epithelial cells it has at its disposal. And ultimately, what you end up seeing is there's a very short window of time where almost all of the virus that you're going to produce during the entirety of your infection happens in a really small window of time. And this is what happens when you have exponential growth of anything. It's at the very peak, actually, is 99.9% of all the virus. Then you end up clearing it after a few days, at least the infectious and culturable virus. And the RNA from that virus might linger on. Think of it like a battleground where you have a war. If you go back after that battle, there might not be any bodies left, but you can certainly go in as a forensics detective and use a PCR instrument and find all kinds of DNA for months or years afterwards. You'll be able to find DNA there. So it's kind of the same thing. We have this massive battle happening in our nasopharynx and in our nose, fighting between our immune system and us. And when you go back in with a PCR afterwards, you bet there's a lot of RNA that's lasting for quite a while. With immunity, it's shortening, but at the beginning of this pandemic, I think the first paper I ever reviewed came from some investigators in China. It was maybe in early April, and they were already finding people, the average person who was getting infected was staying positive for like 70 days in that study. And that was pretty remarkable, but turned out to be quite normal. And that's why CDC, for example, said don't test again for 90 days after you've tested positive once, because you might keep staying positive on PCR for a long time. So you're probably not going to be infectious anymore. That usually lasts only around 6 days. So this is how we often display viral loads. This is just kind of a more practical version of what I just showed. And we usually present it on CT in terms of CT values. And these are, every CT is a count and a cycle threshold. And essentially it's how many cycles, how many doublings of the RNA in this case, do you have to actually have occurred before the machine can pick up that there's a virus there, that there's any RNA initially there. And so it's kind of like clicking the zoom button on your computer. If the dot's really, really small and you can't see it, maybe you have to click 100 times before you can see it to zoom in. If you only have to click 5 times, the dot probably started bigger. And so this is how we normally show it. And normally when we show something like this, it kind of looks like, well, there's a lot of virus there from, let's say, day 3 through 12 or something like that, right? Is that kind of, does anyone disagree that that's kind of like the majority of like that triangle there? But if we take this and we say, well, let's take this off a log scale. It's really hard for human brains to process logarithmic scales. It's really hard. But I'm going to show you this exact same graph. This is what we normally show for sort of the peak. These two graphs are absolutely identical. Just the bottom one is on a linear scale. And what this really shows is that although it kind of looks like you have a lot of virus across this whole like 10-day period of time, the reality is almost all of the virus you're going to have during the whole course of your infection is just here. You can just see where it explodes and then your immune system starts depleted. The human body can only sustain viral replication at an exponential rate for so long. It has to clear it, or you got to go to the emergency room. Now, it's one or the other. You can't just let virus just keep replicating at those high loads. And so it's the most important thing is to find people when they're in this most explosive stage, because that's when you're spewing huge amounts of virus in the population. This is just an example from a study from one of the testing companies out in California, but looking at different viral loads from oral, nasal, and P swabs, and it just shows how quickly you have an escalation of viral loads. Again, this is on a logarithmic scale because it's CT values. Every 10 CT values is a 1,000-fold change. And so you see that you get this real peak. Most of the viral load is in the short amount of time, and then it clears. But the RNA can last for quite a long time. And so a question that's come up over and over is PCR more accurate than a rapid antigen test? Most people, most textbooks, the FDA, most physicians would say yes, absolutely. PCR is the more accurate test. But is it if you're using it for public health uses? So this is another example of what a course of an infection might look like for a person. They get exposed. A few days later, they might turn PCR positive. Let's say in this time frame, day 5 is kind of the earliest that they might have a CT count of 39, and they're just turning positive. Within a couple of days, the virus is going to explode up. You're going to have tons of it. That's when you're having your peak shedding, and then you're going to clear it again. So the majority of all of your virus is going to be just in these few days. And an antigen test might turn positive. It's very likely, in fact, to turn positive during this short window of time, in this case from days 6 through 11, and then it turns negative again. So yeah, you did miss day 5. Both tests missed day 0 through 4. So there's actually only around a day differential here where the PCR is doing better. But when we think about accuracy, specificity for the question we're asking is also really important. And if we're using a test for public health purposes and we're actually going to isolate ourselves for 10 days away from the rest of the world and ask all the people we had dinner with last night to quarantine and all the students in our class to quarantine, specificity and knowing that you're only turning positive when you're infectious is really important. And it turns out that although the rapid antigen test then turns negative right on the tail end of when you're likely infectious, PCR continues to be positive for days and weeks and weeks. And we've known this from the earliest days of really when PCR started being used for detection in clinical laboratories, but particularly in this pandemic, one of the first things we ever knew was PCR stays positive for a long time. It's so massive trade-off. You have a lot of sensitivity, you lose specificity. In this case, you're not losing specificity for the RNA. Yes, there's really RNA there, but you're losing specificity for why you're actually testing, which is, do I need to isolate? Am I a risk to others? During this whole period of time, which happens to be the majority of the time that you're PCR positive, is when you're post-infectious. Telling a person to isolate for 10 days after they're infectious doesn't make much sense. And from a public health perspective, when you start doing that to millions of people, massive economic consequences to the community. So understanding why am I doing this test? Why is somebody doing this really changes the whole idea of what metric should we actually be looking for, and is a super, super high sensitive test, is it actually the most accurate, or is it 60% of the time that it's positive actually a false positive from a public health perspective, which is, do I need to isolate, which is a different question than a doctor might ask. Does my patient with diarrhea have any RNA left in their nasopharynx? That's a different question. And for a doctor, finding that positive on day 20 might actually be a really relevant question. And so this is why differentiating between the two is really important. A different question, do rapid tests work better in symptomatics versus asymptomatics? If you have symptoms, are you actually getting, is the test accuracy better if you're symptomatic? And this has happened over and over. Tons of studies have shown, it's been on the cover of the New York Times, I never thought that PCR and rapid antigen test sensitivities would be on the cover of the New York Times, but it has been. And there's been report after report from the CDC, from the FDA, from investigators all over the place saying, oh, tests really don't work if you're asymptomatic. There must be something wrong with the test in an asymptomatic person. But some of the people in this room can tell you better than anyone in the world that the tests care about the virus. A rapid antigen test doesn't look for whether you have a cough or not. A rapid antigen test just cares about whether you have a virus in enough quantity. And so if we look at this, what is happening? Why do we see studies over and over again say that they don't work as well in symptomatic and asymptomatic people? It's the virus load. Rapid tests work really well for both. In fact, they work identically well for both. The difference is that if you have symptoms, you're just biasing when you are most likely to put that swab in your nose. And you're biasing yourself to put the swab in your nose at a period of time when you're most likely to have a lot of virus. So if an asymptomatic person and a symptomatic person both had 1 trillion copies per mil of virus in their nose and both put the swab in their nose, you better bet they're both going to be positive. They both have 100,000 and the limit of detection is 10,000. They're both going to be positive. It's just a bias that we're seeing over and over play out again and again and again by researchers all over the world who maybe aren't necessarily thinking about these biases inherent in who actually comes to get a swab put in their nose when they're asymptomatic versus symptomatic. If you're asymptomatic, you have no anchor to know where in the course of the infection you are. If you're asymptomatic, you might just be a person walking on the street. Somebody says, can I put the swab in your nose? If you're PCR positive, it is more likely than not that you're post-infectious. And you actually don't want the rapid antigen test to turn positive. That's a false positive for asking the question, do I need to isolate? And that's probably the only reason you're testing if you're asymptomatic. If you're asymptomatic, you're not going to get treated anyway. So it's probably public health use of the test that you're doing that screening for. And so we have what's called spectrum bias. It's been known in diagnostic testing as a real bias for a long time. And that's what's driving these continual discussions. And it's a different question. If I'm asking, how likely is this test to detect an infectious person? It's as good regardless of symptoms. The test, you just simply don't care about the symptoms. So sensitivity and specificity are characteristics of a test and do not depend on the epidemiology of the disease in the population. This, I think most people would say, this is probably like pretty standard textbook stuff here. Whereas positive and negative predictive value depend on the epidemiology and are linked to the prevalence. How likely is it that your test will be a true positive if you're positive, will be higher if you have a high amount of virus in the population. But we usually just assume that the sensitivity and the specificity of the test itself is independent of what's happening at the population level. The next few slides are really interesting because it demonstrates a problem that happens when we have a gold standard test that we're comparing against with that's looking for an analyte and has a property with a half-life that's a lot longer than the test that's under investigation. So in this case, an antigen test, we know turns positive and stays positive when you have high viral loads for about 6 or 7 days. PCR test stays positive for a much longer period of time. And what I'll show is that in the course of an outbreak, this whole notion, this like very standard textbook notion that sensitivity and specificity are independent of the epidemiology of the disease actually starts to break down. And and in some ways, test manufacturers can use it to their advantage, but it also means that all of our studies that we do can be massively biased. And I'll go through an example here. So this is a paper we published in Science a couple of years ago that showed that you could take a cross-section of CT values at a given period of time. So I could walk down to the lab and I could just say, give me all the CT values you had today of your positive PCR tests. And from that one cross-section of samples alone, I could tell you what the estimated RT of the outbreak is. Is the virus going up at the population level? Is it going down? I won't go too much into detail about why that is, but what I want you to take away from this slide is, I'll go into the next to really explain it, but the trajectory of an outbreak does alter the sensitivity of a rapid antigen test when compared to PCR. Sorry about the parenthesis there, I don't know what that is. What I'm showing here is when you are, on the top is an outbreak. This is a simulated outbreak, but we actually have really nice models that allow us to simulate agents, individual people in the computer with their own viral loads and own transmissions. So we have citywide agent-based models. And each one of those people who get infected has a course of disease with CT values. And you can see that the red is when you're at peak viral load. And then the blue, you can see some people will straggle on and keep PCR positivity at high CT values or low viral load for a long time. What I want you to take away from this, though, is that when the outbreak is going up at the community level and the growth rate of the outbreak is high, an RT greater than 1, the vast majority of people that, well, I shouldn't say the vast majority, but a high proportion of the people that you will find who happen to be PCR positive at that one period of time when the outbreak is skyrocketing north, they're actually going to be more likely to have recently been infected. And that's because outbreaks go exponential. So what I show here is like on day 0, you might have 2 cases. On day 2, you might have 4, et cetera, et cetera, et cetera. By the time you get to day 20, you might have 2,000 cases if you have doubling every 2 days. It happens really fast with an outbreak. What that means is that when the outbreak is going up, in this case, 88% of all of the cases that you have at a snapshot in time all occurred in the last 4 days. So in this case, day 16, 18, and 20, 88% of the infections have all happened just in the last 4 days. Meanwhile, the outbreak's been going on for 20 days and all the PCR positive people are staying positive the whole time in this case. But it's because we get stacking with an outbreak that's going up. And so what you can see here is if you draw a line straight through an outbreak at the beginning of it, most of the people are kind of in that red zone. They're like recently infected and therefore have high viral loads, or at least are more likely to have high viral loads. On the other hand, when the outbreak is going down, the opposite is true. You get stacking in the opposite direction. And, or I guess you should say disentangling the stacking. And we can see here, this is a good example. You have a few people who are recently infected and have kind of red high viral loads, but then the majority of people who are still positive are actually stragglers. They're in the blue zone. They have very low viral loads. They're post-infectious. And so what that means is just at a cross-section of time, the fraction of people who have high viral loads represents the trajectory of the outbreak at that period of time. And we've shown in this paper that you can actually get really, really accurate results of the trajectory of the outbreak, the RT, the growth rate of the outbreak, just by knowing this cross-section. What does this have to do with test sensitivity and antigen positivity? It suggests that if you were to go and do your trial, if you're trying to evaluate a new test during the upswing of an outbreak versus during the downswing, you're much more likely to get a good sensitivity of an antigen test when compared to PCR, just based on where in the course of an outbreak you are. If you're at the upswing of an outbreak and you're taking random people off the street and you're saying, hey, how sensitive is this antigen test compared to PCR? Well, you know that if you're just taking random people off the street when the outbreak's going up, most of the positive people are going to have been recently infected. When the outbreak's going down, most of the PCR positive people are going to have been infected 2, 3, 4 weeks ago. So that's going to make massive swings in the perceived sensitivity of that test, which just demonstrates alone that there's a real problem with how we are evaluating these tests. If where you happen to be in the course of an outbreak can create a difference of 50, 60% in terms of sensitivity, then something is really amiss. Something is wrong with comparing those two to each other. You have to stratify by viral loads. And just to give an example of what I'm showing here, if we just look at, in this case, the yellow line is just the 50th percentile. So this is distributions of CT values in the bottom. Don't pay attention to any of the other stuff, just look at the bottom. We could say as the pandemic progresses, rather in this case, as the outbreak progresses, if we look at what fraction of PCR positive individuals are at high versus a low viral load, you see that as the outbreak progresses, that distribution really shifts to the right. And most of the people here, over 50% of the people have CT values that are between, or way over 50% in this case, that are between 30 and 40, which is a very different distribution than what we see at the beginning. So just the fact that that distribution changes so markedly is really important to know when you're starting to evaluate tests. And this is using these agent-based models. Essentially what this shows is if we were to take all comers, asymptomatic people, and we were to just ask a simple question, what is the sensitivity of an antigen test compared to PCR when we're just taking random PCR positive people off the street? When the outbreak is going up, you can theoretically get a maximum of around 60% sensitivity. And that kind of makes sense. But as the pandemic, and actually it's more about the real kinetics are more like this bottom line here. So let's say about 55% sensitive. That's kind of the maximum sensitivity you'd get of that antigen versus the PCR. As the outbreak starts to wane, if you do the exact same study design, you pull PCR positive people off the street and you say, how sensitive is my antigen test? Theoretically, you're going to get under a 10% sensitivity. Literally under a 10% sensitivity is what you would theoretically get if you didn't bias your patients towards being symptomatic. And this is really problematic because the FDA asks for OTC tests. If you want to get a test out into the community and allow people like anyone in this room to buy a test on their own and have an over-the-counter test, it has to achieve an 80 or 90% sensitivity among asymptomatic people. First of all, that's theoretically impossible. It just is. And you'll never achieve it. And so what it's caused is it's just caused the manufacturers, they're not stupid. They know how to game the system. And so they just bias the people. They ask a lot of the right questions. They get to know, okay, you might be asymptomatic, but do you know when you might have been exposed? And if you think you might have been exposed 15 days ago, yeah, maybe we don't want you in our study. And so all it's done is essentially we've evaluated by continuing to compare an antigen test to PCR, we've evaluated how savvy test manufacturers are at recruiting the right people. The numbers have almost nothing to do with the actual sensitivity of the test, which is crazy. But we see it as a good example. The Binax Now test has a sensitivity per the FDA of around, I think, like 90%. But then CDC went and did a field study with it. And said, oh no, we're only finding a 35% sensitivity of the Abbott Binax Now test. How did this thing ever get approved? But it's this issue. It's actually doing really well. 35% makes perfect sense because you're only infectious for about 35% of the time that you're PCR positive. So it's actually a really good number. But it's been really, really confusing for many, many people that this dynamic actually, not only is it hard enough to think about antigen versus PCR and that difference between sort of windows in time, but then you add this other layer where you are in the course of an outbreak and what the growth rate is of an outbreak changes the sensitivity. That's like mind-bogglingly difficult definitely for folks at the FDA in terms of incorporate into the regulatory framework. And all of this can be solved if we just focus on what are the right metrics. Why are we continuing to compare an antigen test to a PCR test? It's like asking an X-ray machine to be as sensitive as an MRI. We know that speed makes an X-ray machine invaluable. We know that if you're an ER physician and you just want to know if somebody's femur is broken, you probably just need a machine that can tell you that. You don't need a machine that can find a hairline fracture scar from a fracture that happened 2 years ago. An MRI will tell you that, but that shouldn't mean that the X-ray machine isn't good because it can't find the hairline fracture. That's kind of the similar thing as comparing an antigen test to PCR. So here's a real world example. This is data from June and July from a large testing operation we set up at the Broad Institute in Boston. What we found, this is asymptomatic individuals in June and July. At this time, every single person who was turning positive on a PCR test was being asked to isolate. At this time, every one of their family members was being asked to quarantine, and any school children or camp children that they were around were also being asked to quarantine for 14 days. But when you look at the CT values, you see that almost everyone, this was at the downswing again of an outbreak. This was right after the pandemic. This is 2020. We saw that almost every person, not every person, but around 80% of people all had CT values that were between 30 and 40. These are violin plots, so they're essentially showing the distribution of population. So in this case, it was week 1. What is the average, the median CT value in Boston amongst asymptomatic people was 35. vast majority of those people were well beyond ever being infectious. Yet we asked them to go and isolate for 10 days. We took all the people that they were around, we contact traced them, we put millions and millions and millions of dollars, billions of dollars into finding the wrong people and putting the wrong people into quarantine and the wrong people in isolation. Because we didn't have a test that was specific to the question we were asking, which was, is this person infectious? Do they need to go into isolation and quarantine? So this is a study from Tim Pito and his group out in the UK that really just shows, this was actually from real live people, and I've just put it into a colored graph. But they just asked the question, what is the sensitivity of a rapid test when you actually stratify by viral load? You don't just ask the sensitivity against PCR as a black and white plus minus. You ask, what's the sensitivity when we stratify by viral load? What they found was amongst these 7 different tests, they had 100% sensitivity for the most important people, the people who are most likely to be infectious. It's a great, great results. But as you get to low viral loads, you found that the people who are not likely infectious, the people with low CT value, with high CT values, low viral loads, the test started to not do so well with. And so overall, if you look at it and you say, okay, what's the overall test sensitivity in these studies? You found around a 54%, a 50% sensitivity overall. But if you ask the question a little different, you say, what's the sensitivity to find people who actually need to isolate? All these exact same tests that just had a 50% sensitivity actually have around a 90-95% sensitivity. It's turned out that the sensitivities are entirely driven by viral load, which isn't that surprising when you think about it. But it's been a real challenge to discuss it. This is another study looking at a surveillance program, very similar. We can see that we saw when people were at their peak viral load, they end up having very high sensitivities, and then it falls off. But when we really need the test to catch the most infectious people, they work really well. This is a study from, our group, looking at some of the data from the UK. And essentially, we tried to show that you can calculate this. If you know at a given time what the fraction of people who are PCR positive, what fraction of them are infectious or have that you expect to have infectious levels of virus, and you know what the measured sensitivity is in your study, then you can just do some really simple calculations to find out what is the actual sensitivity for what you really care about. In this case, might be for people who are most likely to be infectious. And so in here, if you have, let's say, 35% of PCR positive people are infectious at any given time in the outbreak, and I just happen to pick the same number, but 35, and then you go out and study your test and you find a 35% sensitivity of the test compared to PCR, then you can calculate and you say, oh, well, the actual sensitivity for that individual or for that individual test is probably more like 95% sensitive for high viral loads. If, on the other hand, you had 50% of your population who are PCR positive are likely to be infectious at that given time that you ran your study, and you got and then you got an apparent sensitivity in the trial of 35%, then maybe that's a poor test. That test might only be 70% sensitive for the question being asked, which is, am I infectious? So we don't have to kind of be beholden to sort of the data we're just getting from random people off the street. We can actually calculate what is the real sensitivity for public health as compared to medicine. So sensitivity is not everything. For a test to actually be effective in a public health emergency like the one we've had, it needs to be fast, it needs to be frequent. So this is a quiz. You're charged with keeping your school protected and limiting spread in your school. You have 2 options. You have a 100% sensitive test that's going to give you results in 2 days. It's a PCR lab test, has to be shipped out. 2 days is pretty good. The average time, it's faster than the average time across the country. Or you can choose an 80% sensitive rapid antigen test, but it gives you a 15-minute turnaround time. So the question is, which test would you choose? We can do a really simple thought experiment. On the top, you have the situation where you have a 100% sensitive test, but it gives you results in 2 days. And on the bottom, you have a test that's 80% sensitive. It will miss 20% of infectious people, but it gives you results immediately. And use it for a screening program. You have 5 kids walk into your campus. All 5 of them get each of the tests. But in the first scenario, you're using the PCR test and you're shipping it out. Well, what that means is that those 5 individuals, the real world situation is that we're not asking everyone to isolate after they swab. They're swabbing and they're going about their day. So we have those 5 individuals and they walk onto campus and they're waiting for their results in the mix of everyone else, but there's 5 infected people. They all get identified by the PCR test a couple days later. Well, what that means is you had 10 person days of individuals walking around campus. So just put in like really simple public health terms, how many people days infectious were spent by the overall population of infectious people? 10 people days. On the bottom, you have an 80% sensitive test. Oh, I don't want to miss that 20% of people. That's really terrible. But it's a rapid test. It gives you results immediately. So you test. And then in this case, you can have another test 2 days later because it's a simple rapid test. You can ask people to do in their dorm rooms. So yes, you miss somebody, but you extract out 4 of those 5 people. So how many person days in that situation with the 4 test do you have people walking around before they get filtered out? In this case, just 2 people days of infectious time walking around campus. So the lower sensitivity test is absolutely the better test for this use. Because a test doesn't matter if you're a super spreader. If you have to wait 2 days to get the result, you could be teeming with virus. You could be the most infectious person that's ever walked the earth. But that test still has a 0% sensitivity until you get that result back. And that needs to be weighted into your overall sensitivity. That's something that's completely absent from regulatory frameworks right now, from thinking about a test. This idea that a test sensitivity is 0 until you get the result is completely absent. And so what this means is if you have a primary window of infectivity, let's say that's about 6 days, which is a pretty reasonable estimate for this virus. So you're transmissible for 6 days. If a lab-based test returns results after 48 hours, then the best case scenario, in the best world, the maximum effective sensitivity you can get out of that test is only 67% because it misses 2 out of those 6 days of being infectious. So you are guaranteed to already be down to 67% if your goal is to stop infections on your campus. And so we have to look at sensitivity, in my view anyway, through the lens of what are we trying to do? A doctor might not like that. A doctor probably want the 100% sensitive test because they're only focused on the patient. They're not focused on the people around the patient. 2 totally different reasons. And frequency really matters. This is kind of a weird slide to show at this point in the pandemic. But when we published this was like New England Journal and Science, and like this was really a hard thing to wrap our heads around, is that if you only test once with a PCR test, the chances of actually finding yourself as infectious, it's kind of an abysmal test. I should say it's an abysmal test program. So sensitivity, if your goal is to limit spread, it's not about the sensitivity of the test, it's about the sensitivity of the testing program that you've put together. And so if you test, what this is showing is how much infectiousness is removed if you had an outbreak, or how many total infections occur. In this case, if you test every single person every day, you're going to have almost no infections really occur, even with a low sensitivity test and a high sensitivity test. It takes a few days to return. You're going to have very few cases, and that's because you're going to get R below 1 over time very quickly. If you're testing every 3 days, then you're going to also, and testing everyone, you're going to also keep R well below 1 for the most part. As you start to spread out the tests, and there's going to be a lot of people who get infected in between the tests. And so the testing program starts to fall apart. And then if you're just testing once every 2 weeks, you're really not doing anything to stop spread. And if we go back in time and we think about those horrible days when we were driving through drive-throughs and just randomly testing because somebody told us to every month, that program generally didn't do anything. It was a pretty pathetically bad program, but it just seemed like the right thing to do. But the mathematics show us that's not the case. Like we need frequency if our goal is to actually identify the infectious people. And this was really important before because pre-symptomatic spread was really common back in 2020. And so it was very rare for somebody to be finding themselves through a test on their own accord before they started spreading the virus because pre-symptomatic spread was so common. I'll skip that. And so it's just an example. Most people, let's say you had a testing program and you were hosting a conference, a series of conferences, and you had a testing program or you had a virus that for every 100 people that were infected, they would go on and spread it to 130 new people. It's an R of 1.3. That's not good because an R of 1.3 still allows spread to go gangbusters over time. Well, let's say you put in place a testing program that didn't catch 100% of infections, didn't even catch 50%, but it allowed those 100 infectious people to just infect 90. Most people would say, wow, that sounds like a really terrible testing program. You let 90 new infections happen for 100? That sounds horrible. But from a broad, if you take a step back and say, what is our goal? Our goal is to get R below 1, stop the spread. A testing program where you can, on average, have 100 infectious people only infect 90 is a massive win. If you were to implement that, although it sounds bad, you still have 90 new infections, it sounds horrible. Nobody wants to be in charge of that program. But over that same period of time, instead of having an R of 1.3 and having 600 new infections per day after, in this case, 35 days, you'd only have 40 new infections per day. That's a massive win from a public health program, but it's really hard. As humans, we don't like the idea of even letting one error come through, no less 90. And so we look at those things as real problems, and it actually inhibited our ability to get these programs started because people, the front page of the news, anytime people would have a program like a testing program and there was one case that got through and caused 10 new infections, that would be headline news. But what was missing from all those reports was, wow, if they didn't do the testing program, you wouldn't have had 10 cases, you would have had 90 new cases or 120, depending on what kind of conference it was. And so the testing programs, even when outbreaks did occur, and outbreaks will always occur in the middle of a pandemic, if you're getting R below 1 within that, it's an overall win. It's just so hard because the counterfactual is invisible. You don't know what the counterfactual is. You see the 20 infected and you say, wow, the program failed. But you don't have any evidence to support the fact that if you didn't put the program in place, you would have had 200 new infections. So for non-lab-based tests, these rapid tests, they're really well suited for limiting community transmission on numerous attributes. If you want to test for public health, you want a test that's specific for only contagious virus. That's generally a really good thing to get. A rapid test is going to give you that. You want a test that's sensitive for contagious virus. Both PCR and a rapid test are going to give you that. You want a test that's going to be used frequently. Let's be honest, a PCR test is not really something the average person can use frequently. You want it to be fast, affordable, accessible. You want it to have low capital costs so you can actually get the program going and scaled. And you need it to be equitable and inexpensive. The entirety of our entire testing infrastructure for the first year and a half of this pandemic was focused almost entirely on PCR. It was just not, and I started one of the largest PCR testing programs in the world. So I'm not at all against PCR. We just have to define why we're using the different tests. Okay, so I'm almost done, but this has been a massively confusing question for Omicron came around. Everyone started saying, oh my God, the rapid test, I'm symptomatic and my rapid test is negative, and 2 days later, it turned positive. I never saw this before. The rapid tests before were always positive. I didn't have this loss in sensitivity. And so there were studies after studies that showed this, or I should say anecdotes after anecdotes that showed this. And so a lot of people said, well, they must just not be working. But the rapid tests detect a part of the virus that just simply isn't mutating with Omicron. So it didn't even make sense. So what was going on? The media says one thing. The FDA even came out and said, oh, we believe that rapid tests are failing for new variants. I think they said that without any data behind it, actually. Pretty sure of that. But what was really happening, or at least one part of what was happening, is that with breakthrough infections, we already had pre-existing immunity. Huge numbers, the vast majority of the population is probably already exposed at some point, either through a vaccination or an infection by the time Omicron came around. What happens when your body already has pre-existing immunity to a virus and then you get infected with or exposed to that virus again? You develop symptoms, but the symptoms aren't having difficulty breathing when you walk around, and it's not necessarily a cough. It's congestion, it's runny nose. And I remember when the media reports when Omicron came around, everyone said, oh, the symptoms are changing. This virus must be different because people are getting runny noses and congestion that didn't happen before. But it makes perfect sense because the symptoms that were happening now with a breakthrough infection were immune-based symptoms. They're your body like actually responding really quickly. And our immune cells are some of the best sentinel cells. They're the best tests in the world to find a virus. They can find one little virus and they can explode and cause all kinds of cytokines and cause us to be inflamed and have symptoms. And so people got symptoms to this day. They're getting symptoms really early. And I always try to tell people, like, remember to take a step back to 2020. The thing that was so unique was pre-symptomatic spread. People weren't getting symptomatic until they had already hit their peak viral load. That's really unique. What made that unique was the fact that the virus was sliding into us, was amplifying and replicating totally undetected for days. And then finally, remember the CDC would say, don't even bother testing for 5 days after you've been exposed because the virus hasn't replicated enough. And then it would replicate. And then on like day 7 or 8, people would start feeling difficulty breathing. That was one of the basic things, or difficulty smelling. Those are symptoms of the virus harming parts of your body. When you start to get symptomatic on day 2, it's oftentimes your body responding and recognizing the virus. Why? Because you actually have immunity. You've been exposed, your body's already learned. And so simply what was happening, or at least a large part, is that people just started testing themselves earlier. In that window of time before the virus had a chance to grow up past the limit of detection, people were just, their body's much more sensitive than the test. And so the body's saying, oh, I feel very good. Maybe I got exposed a day or 2 ago, and so you test and you're like, oh, it's positive. Then you're still not feeling good. So 2 days later, you test and you're positive. The test didn't stop working as well. It's our behavior of when we use the test really changed because our body alerted us earlier. It's something we would have loved to have happen in 2020. We would have had much less spread probably if our bodies alerted us on day 1 or 2 that we were exposed, but unfortunately we didn't have immunity. So to facilitate appropriate evaluations of tests, as we look to new pandemics and new problems, I feel that we really need new measures of sensitivity that have to be considering why are we testing? What is the goal of testing? Most loss in the sensitivity of these tests comes from not detecting residual RNA. There is the window of time when you have really low viral loads and it's on the way up. And yes, absolutely, it would be really nice if a rapid test could detect in that window of time, but your chances of actually even putting the swab in your nose during that short window of time are pretty slim compared to the loss in sensitivity on the tail end. So a rapid test with 50% sensitivity to detect any PCR positivity may well be recalibrated to actually be 90% sensitive for the question that many of us have been asking for the whole pandemic, which is, am I infectious? Do I need to isolate? But our regulatory structure continues to be focused on medical diagnostics. Really, I would say at the complete expense of appropriately evaluating tools for public health. We chose tools during this pandemic that gave us results 10 days later, instead of a rapid test that gave us results that might have been a little bit less sensitive 15 minutes later. So we chose 0% sensitive and 0% effectiveness over 80 or 90%, just because of how we were measuring and thinking about the analytes we're looking for. And what happened is in the US, surveillance using, let's just throw a number out there, 98% sensitive PCR had extremely low sensitivity to detect cases in time to act. In fact, our entire surveillance program with PCR in the first year or two of this first year or so, we estimate to be under 5% effective sensitivity to actually detect people in time to act, which is a remarkable problem when you think of how much money went into the PCR infrastructure because we thought those tests were the right ones. And so despite widespread testing, it really wasn't likely to curb transmission at all. And that's effectively what we saw. So I'll stop there and happy to take your questions.
For giving a really exciting talk. We'll do a couple of questions in the room and we'll do a couple of questions online, of which we have over 100 people. So great crowd. Okay, question over here.
With immunities and vaccines available now, how would you build a program for the ED and urgent care, PCR or antigen testing?
If I'm in an ED or an urgent care, I'm always going to put a rapid test first. Why? Because if it's positive, your job's done for $3. Like, it doesn't have to be an and, I mean, it doesn't have to be an or. So I would always say to everyone, even if it's a crappy antigen test, just do the damn antigen test, as long as it's specific. If it's going to give you all kinds of false positives, then you don't want the hassle. But if it's really specific, and I didn't go into specificity here, but rapid antigen tests turned out to be amazingly specific. 1 in 2,000 false positives or so. So I would always just say, the damn rapid test, and so it's so simple. And then you can have an algorithm, which is just, if you're positive, go somewhere else, go isolate. We don't want you infecting people. If it's negative, and still get the PCR, you've spent $3. So I feel like there's been this ongoing discussion, like which one to use. I've always just said, $3, they should be 90 cents. They cost 30 cents to make, and this is why I think the US government should be producing them. We for too long had $25 tests, and it kind of put us in this, and they were not abundant. Now we have a mass abundance. In fact, I believe that there's probably hundreds of millions of rapid tests sitting idle. So I think it's just a great tool to just have there, and then do the PCR if you're concerned. But I think the other part of your question, I wasn't quite looking at that. We have vaccines and we have therapeutics, and we are on the off ramp of this pandemic. It's not all epidemiologists want to say it. The fact is, like, we're vaccinating. The vaccines are working really well. We have therapeutics for people who actually get sick. I've probably spoken more than quite literally anyone in the world about the benefits of serial testing, but I don't believe that serial testing at this point in time is the right thing to do. Not in terms of just like rote screening. We've kind of gone beyond that, and I do think we have to look around at who the patient population is and try to understand, is it the right thing to do? I do think rapid antigen tests are just so darn cheap and easy that it's kind of an easy throwaway thing to just say, just do it. Costs are really high. But would you want to always do the PCR then if there's still costs and logistics incurred? I'm not sure at this point for everyone.
More question from the audience?
We can get the PCR back in an hour.
Okay, so we just want to repeat the question.
So what if we could get the PCR back in an hour? It's kind of the opposite. I'd say, sure, do the PCR. But what do you do if it's positive? Knowing what we know about how long you stay positive for PCR. If the person's in there for symptoms, like they're in there for COVID, absolutely, like do it. I'd still say do the rapid antigen test, because you'll know if they're blazing high, you'll literally know in 10 seconds. We've all, maybe not everyone, but I know on myself, when I was sick, my rapid antigen test literally turned positive in 10 seconds. So even just that hour can cause infections in an ED. But I actually do think it's good, but then you need to say, but it's low specificity for what we actually care about. Like, what happens? What are the expenses incurred if that person turns out to be positive? What do you do? At what point? Then you have to put them in an isolation room. Then it costs tens of thousands of dollars versus a few hundred or a few thousand. So I think it's a really difficult trade-off. And this is where I think CT values, even though for the most part, the FDA has not allowed CT values to technically be used. At Brigham, we would give our doctors would ask for CT values all the time. And at least then if it's CT, if you get the PCR and it's a CT value of 18, isolate them. You know where they are in the course of their infection. If it's 39, maybe ask them where in N95. And if they're being admitted, test them again tomorrow. And if it's still, or test them again in 6 hours. If it's still 39, you can be pretty darn sure they're at the tail end of their infection, because you don't start an infection at 39 and not go to 25 and within 12 hours. And so serial testing for that purpose can be really, really powerful.
Okay, we'll do 2 questions, and then we'll probably have to end it 2 questions online. And I apologize to everyone online. There's tons of questions, but I'm gonna have to curate. So to maybe riff off of Dr. Rogers' last question. So if the analytical sensitivity of an antigen test is worse than a PCR test, such that the PCR test detects 2 days before the antigen test would, then the time delay of sending a PCR test to a central lab is mitigated. The result in a pre-symptomatic case would be better in this case, wouldn't it? Question mark.
No, because I've heard this so many times, and what we fail to realize is that is only the case in a really, really rare example when you happen to be putting the swab in that person's nose right as they've passed the threshold of sensitivity of limit of detection for PCR. So you could put that argument in place, but that is making an erroneous assumption that everyone you're detecting as positive on PCR is not already a super spreader. So with that type of program, you'd say yes, but what you're missing then is the people who are walking in and getting that swab put into their nose at that time, who are already super spreading right now and are spewing out trillions of viral particles. So it's not worth the very small number of people who for whom that balance actually works out, because the vast majority of people who are infectious are not just starting, they're actually here, they're actually going to be positive. And so that's kind of like this human, I've heard it so many times, and I think we have like this human kind of like propensity to assume that if this is somebody's viral trajectory and we have a program like that, we just assume that that person's going to walk into our office and get the swab stuck in like right when they're about to pick up. The vast majority might be walking into our office like right here or right here. And so it massively outweighs that risk. And that's something that I've talked to the FDA about too. And I don't believe that it's been understood yet.
Right. Okay, so one final question, a public health question. So interesting points about purpose and consequence of tests, who benefits and who is impacted by the consequences. Do you have thoughts about the financial burden of testing moving forward, given that during the pandemic, there was a big push to shift costs from public health to private health insurance, even in cases where people were testing for others' benefit, not for the individual medical situation?
Absolutely. I believe we live in a healthcare system where our payers pay, and by payers I mean insurance companies, and I've always said like it's kind of crazy in a pandemic to ask payers to pay. And I'm not particularly pro, it doesn't matter, but I wouldn't normally want to be saving, Aetna a bunch of money. But the reality is they cover their people. And if you're using a test for the benefit of everyone else, I don't think it was the right thing to push that payment on. I think this is a problem with not having a collective pot of money, and I think Europe did it a lot better. A lot of countries did a lot better because they didn't have to struggle with these who's paying kind of thing. And I think there are times when I definitely think if you're using it for yourself, for your medical purposes, to know if you're infectious, like sure, ask your payer to pay. But a school that's forcing everyone to, or business that's forcing everyone to test 3 times a week, of course the payers are going to push back, and rightly so, because those tests are clearly not for the benefit of those individuals, for the benefit of the corporation, and for the benefit of the public. And so I personally don't think that, I think that we have to really hit those issues head on. And I know there's some really good people at BARDA and elsewhere who are starting to think through the financial implications of what happened in this pandemic. And these kinds of questions, I think, are so complicated, but they're so important for us to figure out now in peacetime, relative peacetime before the next thing hits.
Okay, thank you all for coming. Thank you for those of you online, and thank you, Dr. Mina.